So thanks, Dr. Cohen, for this case. This is a 41-year-old man. He's had blurry vision in the left eye for 5 days, and then part of his kind of extended history in January, months prior, he had a flu-like symptoms, and apparently he tested negative for RSV. He's got a history of diabetes. He had a small growth on his neck removed. He takes metformin, atorvastatin, and acyclovir. His vision in his right eye is 20/30 in J2. His left eye is a bit worse at 2200, and then near is 2400. IOPs are 19 and 21.
Okay, so we have a color fundus photo of the right eye. Media looks clear, nerve pink and sharp, maybe slightly enlarged cup, vessels, little bit of maybe some venous beading, and there's some kind of scattered white dots mostly in the periphery, especially superiorly and nasally.
I get maybe some exudates down here.
Okay, yeah, and some exudates, inferior mac. Left eye looks pretty similar. Media is clear, some venous beading, slightly enlarged cup. Again, we see those kind of scattered hypopigmented spots that are mostly supraronasal.
And then do you notice anything kind of in the paraphobia?
Maybe a little bit of cercinate exudate.
Yeah, and then perhaps I can convince you there's something here too. We'll get a closer look at that.
Okay, so we have autofluorescent photograph of the right eye, and you can kind of see some venous beading, and you mostly see these hyperfluorescent spots scattered throughout the macula and superior and inferior and nasal.
I would say irregularity of the contour of the vessels, because venous beading for us is kind of code for severe diabetic retinopathy about to go proliferative. So just like the veins look irregular.
Okay.
Just the way we talk.
Irregular veins.
Yeah, that's caliber. They're like a caliber.
I disagree, Steve. I was always told that
Yeah.
venous beading was one of the earliest signs of diabetic retinopathy. So,
Really?
yeah.
All right.
Okay. Left eye, we see kind of something similar, a little bit blurrier, but we can kind of see those areas of hyper autofluorescence, and they're more concentrated superiorly and then in the macula parafoveally. And we have an OCT, looks like a horizontal slice of the right eye. And media looks clear. Looks like the architecture of the layers looks appropriate, good foveal contour.
Yeah.
How about in the vitreous? Can you see any those spots in the vitreous side?
Okay, I see a couple spots. Okay.
Sometimes those are nothing, but sometimes those are something. And
Okay,
then
possible vitreous cells. Okay.
yeah, possible vitreous cells. And then if you follow the RPE, just nasal to the fovea, so you go.
Okay, I do see some
It should be pretty straight.
some irregularity in the RPE.
It's not perfectly straight. This patient's pretty young, I think, aren't they? So yeah, so that should be straight on, and then there's some bumps in it. So it's a little bit off. I mean, it's not in an older person, you wouldn't call that, but in a younger person, like, yeah, it's not quite right.
Okay. And we have in the left eye, I'm not seeing maybe a couple spots in the vitreous, good foveal contour. And we again see this kind of irregularity in the reflectivity of the RPE.
Good.
And FA, we have the AV phase of the FA. We see we're kind of looking at these hyperfluorescent spots that are again scattered, mostly superiorly in this eye, and some venous abnormal caliber.
You get stuck in the middle of that.
You are so politically correct. Can't stand it.
I'm here all the time. It comes and goes.
Okay, we have a later phase in the FA. The arteries and veins are still full, but we see kind of highlighting more that the hyperfluorescence in those spots. It doesn't look to me like they're enlarging.
And then there's one other finding on the nerve. You got to look at the early and the late to see it. So this is 1 minute, this is 5 minutes, and this is later, 14 minutes. So what's happened to the optic nerve?
It's getting the margin is getting a little blurrier, so is leakage around the nerve?
It's brighter. It shouldn't really be brightening so much. So it's lighting up, or it's staining, or
Oh,
it's
staining.
leaking.
Okay.
Yeah, it's just leaking, staining like off the nerve. Yeah, go back to the first one and the last one. So it should pretty much stay like that in the later phases, but it doesn't.
So left eye, we have this is kind of the beginnings of the arterial phase. And then the lamellar phase, we can kind of see the abnormal caliber in the veins there. In the AV phase, and we're kind of seeing those spots start to light up later in the AV phase and into the venous phase. We have a section through the superior section, and we can kind of see those hyperfluorescent spots superiorly. And yep, again, those hyperfluorescent spots, maybe a little bit of staining in the disc, and some more of those hyperfluorescent spots. And some blurring in the disc margin. And we can see this area of all these spots that I don't think that it's leaking.
Well, it's blurring up some. And then the other thing is you're talking about the spots, but then if you draw a line around this thing, I probably can't see my pointer. Yeah, but that area that's confluent, you see how they're kind of confluent there?
Mm-hmm.
So there's another word you could use for that. That might help you some. So when they're confluent like that, if they're spots, they're spots, but they're confluent, we sometimes call it like if you won a race, you might get the top 3 finishers might get a plaque. So we'll sometimes call that like a placoid lesion, if it's which gets you into sort of a different zone with uveitis.
Okay.
And the staining of the nerve, which is true in both eyes, there's also something you'll generally see in an eye with inflammation. So with the cells on the OCT, the nerve lights up, you're probably dealing with an inflamed eye.
So this is ICG.
Okay, so we have the ICG of the right eye. We can kind of more definitively see the choroidal vasculature here. And vessels appear pretty normal caliber. Okay, later phase, we're mostly looking at the choroidal vasculature. It doesn't highlight those lesions or the placoid lesions as well.
So here at the last one, you're getting go back one slide. So at the very end, you are kind of getting a little darkening. It's a little impressionistic, but that area should just be light. You shouldn't see that dark.
Okay. Okay, ICGA of the left eye. You can see the choroidal vasculature and the arteries and veins pretty well here. A little hypofluorescent in the fovea and okay.
Yeah, I think kind of the same deal. We can kind of see the.
As Dr. Cohen was saying, yeah.
All right, so just to review, we had a 41-year-old diabetic. He had a flu-like illness earlier this year. He's got some interesting subtle lesions in the macula in his fundus photo. His OCT showed thickened RPE with some ellipsoid disruption and maybe even some cells in the vitreous. He's got late staining of those lesions on the FA and some hypofluorescent areas corresponding to those lesions on the ICGA.
Okay, so I think kind of based on the presentation, I'm thinking maybe one of the white dot syndromes like AMPI. Doesn't quite look like serpiginous, but it was kind of concentrated around the nerve, and maybe VKH as well.
What about like posterior uveitis?
Oh yeah, posterior uveitis.
So so once you go down the uveitis road, which can be very, daunting. It's challenging to figure out what's what. You did the white spots. Another nice way to think about it, because basically, if you want to make them better, you want to put them on steroids, right? But if you want to put them on steroids, you got to make sure you're not treating an infectious case. We have a case in our practice right now. We've all been looking at it. It's like, I don't know what that is. So you need infection or non-infectious. So for non-infectious, I think the white spots are good. For infectious though, because before you give them 60 milligrams a day of steroids, you want to rule out an infection. What are some infectious uveitis when the retina is involved? You got to be careful of.
Syphilis, TB, Lyme, possibly.
Lyme's interesting, just so everybody in the room knows. All the experts that I've heard, I go to some conferences, everybody says Lyme does not cause uveitis. Like people practicing in Lyme, Connecticut say they've never had a case of Lyme uveitis. So we always order it, but you probably shouldn't. And that's okay to say that because I've ordered it before, but everybody says you really probably should. If you find it, it's probably just a coincidence.
Viral causes.
Yeah, the viral. What about the herpetic ones?
HSV.
We got some retinal whitening. Those are scary. I mean, those like acute retinal necrosis is terrifying. It's probably not that, but it could be. So you've got the viral ones. So you've got the infectious, non-infectious, and then the white spots. Good.
Yeah, so we pretty much covered everything on my list. So this patient got some labs done. His RPR came back positive with a titer of 1 to 128. And then he got the treponema antibody, which was also positive. He was hospitalized and treated for neurosyphilis with IV penicillin. And then 1 month after treatment, these are his OCT scans. So on the right eye, he had these subtle kind of nasal lesions here in the RPE. And then in the left eye, kind of the bigger lesions, you can see they responded well to the treatment. And then his vision ended up pretty good too.
There's that premacular bursa you guys were talking about. You can see it really well in those pictures.
Can I walk back my earlier comment? I want to say that venous irregularity is one of the earliest signs of diabetic retinopathy, not venous beating.
Okay, thank you.
Okay, the reason being, isn't venous beating one of the signs they used in staging fairly advanced non-proliferative retinopathy?
Yeah, that's the one. That's the 1, 2, 4. And the venous beating, if it's really venous beating, which I have very few pictures of, it's supposed to be neovascular buds because the neovascularization comes off the vein. So it's supposed to be little tiny buds of or something like that. It's trying to form neovascularization, I think. So yeah, so venous irregularity. All right, thanks. Go ahead with this case.
So just this is like the original lesion, and that's how we ended up. So we responded very well. All right, so we're going to be talking about everyone's favorite spirochete, the Great Masquerader, syphilis. So syphilis.
That was really cute. You should go back.
Oh, that's so cute.
Everybody's favorite spirochete. So Treponema pallidum is a microaerophilic spirochete. It interestingly only infects humans and baboons. It doesn't have a TCA cycle, so it performs a minimal amount of metabolic activity. And kind of because of this, it can get everywhere and is difficult for the immune system to deal with sometimes. So it can present in a variety of ways. So it's known as the Great Masquerader. Transmission is generally through sexual contact, but it can also happen in utero across the placenta, or rarely during birth with contact of an active genital lesion. So epidemiology, there's about 12 million new cases annually globally. Incidence was declining in the US from 1990 to 2000, but since then it's been steadily increasing. It's almost doubled in the past 5 years. It's also much more common in men. So risk factors are obviously sexual contact with an infected individual. The transmission rate is 30 to 60%. Concurrent HIV increases the risk of ocular manifestations. And ocular syphilis is often how HIV is diagnosed. And then men who have sex with men is the strongest risk factor in the US for people contracting syphilis. The pathophysiology, so spirochetes appear in the lymph nodes mere minutes after someone's inoculated, and within hours they're widely dispersed throughout the body, including in the CSF. Neurosyphilis results when the immune system can't clear the bug from the CSF. And ocular manifestations, which may happen in up to 10% of cases, can occur in really any stage, primary, secondary, or tertiary syphilis. And as the Great Masquerader, it can really affect pretty much any part of the eye, anywhere from the front all the way to the back. And the most common presentation is a uveitis. If the patient's HIV positive, it's typically a pan-uveitis, and if they're HIV negative, it's more often isolated as like a posterior uveitis. And then retinochoroiditis is the most common posterior pole manifestation. So just to review the stages of syphilis, there's 4 stages. Primary syphilis involves the painless chancre. Usually it's on the genitalia, the site of inoculation, but it can occur in other places. It usually happens 2 to 4 weeks after exposure. And then the chancre usually clears on its own. Secondary syphilis happens a bit later, 2 to 8 weeks after the chancre disappears. You get some systemic symptoms, fever, headache, pharyngitis, lymphadenopathy, and then the classic rash involving the palms and soles will occur during the secondary stage. And then you can also get condyloma lata, which are like warty-like lesions, usually seen on the genital mucosa. Then you have latent syphilis, which can be divided into early and late. Early latent is within a year of infection. It can be asymptomatic, or patients can have some vague symptoms like anorexia, nausea, joint pain, or hair loss. And then you have tertiary syphilis, which usually occurs over a year, and it can actually take decades to show up. You can get cardiovascular system involvement, especially of the aorta. And then you can get gummas, which form in the skin, bones, or within organs. And then the latent stages. So just going to focus on the posterior pole manifestations of syphilis. So again, retinochoroiditis is the most common presentation. You can also have a chorioretinitis, neuroretinitis. So syphilis can kind of get into every part of the retina. Or the posterior pole. You can have a retinitis that can be necrotizing or non-necrotizing, and it can mimic ARN or porn. Typically, the syphilitic lesions are described as more yellow than white, contrast from the herpetic retinitis. You can get a vitritis, like we may have seen in our patient, and then a low-grade retinal vasculitis is usually present. You can have a pre-retinal precipitate, overlying an active retinitis, and I'll have pictures of that. And then you can also get retinal detachments. Exudative, which is uncommon, may improve with antibiotic. And then the other kinds of retinal detachments are harbingers of a poor visual prognosis. So this is an example of those pre-retinal lesions with active neuroretinitis, nerves involved, and then these little light-colored lesions. They represent aggregates of white blood cells. And then this is kind of the main topic of this case, I guess, is acute syphilitic posterior placoid chorioretinopathy, or ASPPC. It was first described by Dr. Gass, and these pictures are actually from his original paper. They're pretty nice pictures. It's technically a rare manifestation of ocular syphilis, and it's relatively specific for syphilis. The lesion occurs at the level of the RPE and disappears with treatment, just like we saw in our patient. And like I mentioned before, you can distinguish it from herpetic or toxo lesions. Syphilitic has more of a ground glass appearance to it. And then the herpetic or toxo have more of a white coloring to them. And some authors suggest that this ASPPC just may be an early stage of posterior uveitis. There's just another picture of that. On OCT, the spectral domain OCT is the gold standard for the diagnosis of ASPPC. You'll see choriocapillaris and RPE involvement. The lesion will be at the level of the RPE. You'll have an intact ELM, ellipsoid zone disruption, and a thick granular hyperreflective RPE. And so some cases may have subretinal fluid, and it's been suggested that that's generally in just like very early stages.
So your asterisk, if you go back to that picture, your asterisk is showing this choriocapillaris thing, which I'm not that good at picking up, but I think what it's showing is there's a cellularity there, or is it all little spots? You don't know what the asterisk is supposed to show, do you? I think it's a little more cellular than it should be. And then the other thing is the RPE lesions on a classic one, which this was not, you get these pyramids, which are kind of cool. So I've had a couple patients in our practice where you'll see, like, they look like drusen, but they're kind of like a pointy pyramid periodically, and those are almost always syphilis. And the presence of like an inflammation or sudden onset or vision. And honestly, nowadays drusen, like atypical, I've had patients with atypical drusen, they just didn't look quite right. And syphilis is just so common now. But the OCT is good. All right, I think that's a choriocapillaris thing, which I have trouble parsing.
Right, so then on autofluorescence, impaired metabolism of the RPE leads to lipofuscin and photoreceptor outer segment accumulation. And so you end up with these hyperautofluorescent dots. On FA, you have early hypofluorescence with progressive hyperfluorescence. It may be described as having a leopard pattern. And then you can also have late leakage and hyperfluorescence, and revealing an active leading edge.
Hi, this is Don Noel. Can I say something?
Oh yes, absolutely.
Yes. Also, I want to point out like two things like characteristic for syphilis on OCT, like some tongue-like appearance on OCT, like above the ILM and also pyramidal shape under the RPE. So if we see those things, they are characteristic for syphilis. And also, I joined during the discussion about Lyme disease, like as differential diagnosis in this case. So I think if we have like Lyme disease as the differential diagnosis, we need also to rule out Bartonella and Slagle. Of course, there need to be like some risk factor like pet exposure, because I remember I saw a case like in Portland end of July at the end of my fellowship training. And this patient had like neuroretinitis and plus significant vitreous inflammation. So, sorry, we had like Bartonella and Lyme disease as on top of the differential diagnosis. So the thing is, IgG IgM was positive for Lyme, but negative for Bartonella and Sele. But the Western blot was negative for Lyme. So we put the patient like on like systemic therapy, antibiotic first before we put the patient on corticosteroid because we need to treat the inflammation. And when we check like, weeks after, so Bartonella and Sele was positive for IgG, IgM, and Lyme still Western blot negative and IgM, IgG negative. You know what I mean? Sometimes the clinical presentation can be confused between Lyme and Bartonella and Sele. Yeah, but I agree with you. Lyme usually doesn't cause like uveitis, but we can have sometimes a significant like intermediate inflammation, like vitreous inflammation in both Lyme and Bartonella and Sele.
All right, thank you. Thank you. Appreciate it.
You're welcome.
Thank you, Dr. Noel. So I'll move on to ICGA. You'll see variable hypofluorescent areas, and that's possibly due to choriocapillaris hypoperfusion by the affected RPE, and you get a better demarcation than on FA, so it's more sharply demarcated. So just going more generally, just kind of to review the diagnosis of syphilis. So you have non-treponemal and treponemal tests. The non-treponemal tests are sensitive and are useful for screening. They use the Wassermann reaction, where antibodies react to bovine cardiolipin and will precipitate out of solution. Unless there's syphilis in there, then you have to dilute it, and so you get your titer. The RPR is variably sensitive depending on what stage of syphilis you're in. A false negative can be associated with HIV and late stage syphilis, and many things such as IV drug use, HIV, hepatitis, Lyme, and autoimmune disease can cause false positives. Then there's the VDRL, which is very specific for neurosyphilis and can be used to test the CSF. Even if the serum is negative, the CSF may be positive. If the patient has an HIV co-infection, the VDRL interpretation of the CSF is not necessarily well understood. The non-treponemal tests can be non-specific, at least the serum ones, and they can be susceptible to having many false positives. And depending on the stage, a significant amount of false negatives. And then if a patient has a super high antibody level, they might get this prozone reaction, which results in a false negative. And then just to kind of review causes of false positive serologic tests, this is from one of Dr. Margot's papers. But there's a bunch of infectious causes, and then autoimmune and non-infectious causes as well, such as malignancy, pregnancy, if somebody's had blood transfusions, lupus, etc. Then the treponemal tests are generally thought of as the confirmatory. They're both sensitive and specific. They can't necessarily distinguish from active disease versus a past infection. So once you're positive with a treponemal test, you'll be positive for life. You have the FTA-ABS, which I believe is the most common. Then you have these other microhemagglutination, the TP, PA, and the Western blot. In order to diagnose neurosyphilis, the CSF needs to be tested, technically speaking. And then immunoassays are more sensitive than RPR in very early or very late stages, and those are EIA and CIA. So the CDC, there's a couple of different testing algorithms. So generally, the traditional algorithm starts with a non-treponemal test, and then if that's positive, you can move to a treponemal test for confirmation. There's a reverse algorithm that some places will use depending on the prevalence of syphilis. And the CDC says, really based on the prevalence, kind of what kind of environment you're in, and the cost of the test, there's not really an optimal order, so you can do both. In some places, just do them simultaneously. Management, so ocular syphilis is treated as neurosyphilis. A large percentage of ocular syphilis cases will actually have neurosyphilis, and that's treatment with IV penicillin. G, 18 to 24 million units per day for 10 to 14 days, or 50,000 units per kilogram. And then if there's an allergy to penicillin, literature says that you can try Rocephin or azithromycin. And then this is kind of a nice favorite board question. If a patient's pregnant and they're allergic to penicillin, how do you treat it? And that's just with desensitization.
And I think you desensitize each dose, right? Each time you dose them, you have to desensitize them, dose them to penicillin, and then do it again each time.
I've never done it, but it sounds like a lot of work.
Yeah.
Systemic steroids are often co-administered, but it's important not to start the steroids before starting them on antibiotics. And then during treatments, this Jarisch-Bruchsheimer reaction can cause patients to have decreased visual acuity, some disc edema, macular edema, and convolvulus spots. So prognosis. So if the patient's had the uveitis for a long time, they've had symptoms for a long time, if they have macular edema or HIV, these are all harbingers of a poor visual prognosis. And then interestingly, if they have vasculitis that's seen on the FA, it's a relatively favorable prognosis. If they have anterior uveitis, or if they also have like a systemic neurosyphilis. And then here's that finishing slide.
That's very good. Thank you. Yeah, in my 30 years of practice, I think the first 20 years I might have seen one. In the last 10 years, I've probably seen 10. It's just unbelievable, the amount of syphilis. You guys are getting like crazy in the ER, aren't you? In that case, wasn't the fluorescein in this case did not block early, so it wasn't a perfect case. I think we might have lost 2%.